let's talk. I've heard myself talk for an hour, and although it brings great enjoyment to me, it won't make for meaningful for you. So let's just talk together. The second thing is we've all sat through presentations where we walk out going, wow, that was an hour of my life I'll never get back. And I really want to avoid that. So let's spend just a second talking about what we're hoping to get out of this. And as we start talking, if we head down the wrong path, if you feel like there's a better path to go, let's go down that path. Let's work to make our goal when we leave here today, we feel like it was an hour well spent. Is that okay? Can y'all tell me who you are and like your interest or your how PEDS, the topic of PEDS, drew you into this? Can we start?
Goodness. Which half? Goodness. I've got 5 children to begin with and a grandchild.
That's awesome.
So that's, I'm in PEDS. I love PEDS. One of the subjects that I actually like to teach is OB and childbirth, and teach that in the community.
Oh, very cool. And this is the first year they've got a pediatric track at this.
They actually keep pediatric tracks. So this isn't, I'm doing an on-hand childbirth emergency where I actually bring the OB managers in, give them scenarios of
fabulous.
Do difficult births.
Okay.
I don't give them easy ones.
Yeah, good.
But I'm also part of the medical response system as well as the general disaster medical assistance team. And one of the things that we don't do well in a disaster situation is pediatric management. Everything is geared towards adults. And they found out in Haiti real quick that PEDS was really lacking in providers, the type of physicians that were there. That it was more of a forte that we need to pull more pediatricians in, more pediatric practitioners in general.
Okay, that's great. I hope it was all right. It's a small group, so I just said hi, I'm Roger.
And you don't want your intro?
Yeah,
okay.
Yeah. But thank you. You're very kind to offer.
You're welcome.
Okay, tell me about your interest in PEDS.
Well, my name's Ann Mortensen. I'm director of an assisted living home, so this is the other side of the gambit for me.
Uh-huh.
But of course, I have a son and I have a wonderful grandson that was taking care of children's hospital for the first part of his life. So anything that I can learn that I can help someone else, I'm in the right place.
That's fabulous. Okay, Dawn, you're just here because.
I'm here. I'm the Regional Inclusive Emergency Planner, meaning I lead the 16 jurisdictions in Hampton Roads Planning District and making sure we're including all of the community, people with medical needs and disabilities. Prior to this, I was a local emergency manager for Anchorage, Alaska.
Were you really? Is that your connection with
yes,
the
last
last
I got to work
person?
with Mary for years and years and years, and that's how I know she's absolutely fabulous. And in Alaska, we struggled with medical coordination until Mary took over. And PEDS, by the time I left a little over a year ago, wasn't even a topic of conversation. And it also, I've been here a little over a year, it has not been a topic of conversation in Hampton Roads yet either for as far as special needs planning or with the Healthcare Coalition much. Some, but not a ton.
Okay, all right. Sarah, who are you? Why are you here?
I am here to support my husband because I like PEDS too.
Sarah is my wife, a fabulous supporter, and the mother of our 7 kids. So I joke when I teach Instant Command, if you want to see Instant Command alive and well, watch her take kids to a grocery store. You know, you have your operations, you have logistics, you clearly have safety. You know, it's pretty weird. Okay, tell me about your interest in PEDS.
Well, I'm the administrator of an assisted living facility.
Okay.
It's just a small one. We have 21 residents there.
Okay. And are there any pediatric patients there?
No, it's just like lower than 25.
Oh, okay.
So still we can be not the baby, not that big.
Right.
So we want only to know about the safety.
Yeah, right. Okay, that makes sense. So you're in the same facility with him? Okay.
We are in the same facility.
All right, fabulous. All right. Remember we said if we're heading down the wrong path, that's all right, we'll switch around. So one of the things that is interesting to me about, well, let's start with this. What is a pediatric patient? What defines pediatrics? I'm good with any of them. Take it away.
Pediatrics typically is anything under the age of 7 field. But you also have to consider the older adults that have pediatric mindsets, i.e. maybe autism or your Down syndrome, So you've got
Developmental
adults that
disabilities.
have the developmental disabilities that have a pediatric age mentality.
That's good. All right, anything else?
Your dementia residents fall into that category.
All right, that's good. That's really an interesting nuance. Dementia. I was going to say, can we? Thank you. I forgot to mention two other rules. The first is this: I'm a guy, which means I can't spell, so no heckling. I'm also a guy, which means when I write, I tend to go up at an angle. Again, no heckling. That's just rude. Dementia. So one of the things that's interesting is in this, adults can look like peds of certain ages. That's an interesting dynamic. I like that. You said 18 years old for treatment modalities, so for physical, like drug usage, tell me what the age is.
Drug dosage basically needs to be weight dependent, not age dependent.
Okay, good. So for kids, drugs are weight dependent up until what point?
Is it like, okay, not being a medical person?
That's all right.
I think about Tylenol or, ibuprofen, and it usually says up to 12 and then 12 and over.
That's a special age. Most people think that that's a 13 rather than a B. Sorry about that. It hits that first rule of I can't spell, can't draw numbers either. Most people clinically say that a pediatric is 12 to 13 or less. At the point that they hit adolescence, that's when physiologically they tend to mirror more like adults than kids. So that's when you start changing drug dosages and how you calculate and all that kind of stuff. There's also another break where peds goes into like infants or neonates. What's that age?
The neonates is up to 28 days.
Okay, so neonate is 28 days.
And then you figure you've got your infants up to age 1 or 2. Then
Yeah.
toddlers, 3 or 4.
months.
I think that 2 years old is kind of another magical milestone. So when you start talking about physiological differences of kids under 2, things change a lot. Organ size is different. The surface area, so your skin to interior ratio changes. Why would that be important? Why do we care about that as it relates to a disaster?
Different types of trauma.
Trauma? Anything else? In a disaster, there are 4 ways you can get bad stuff into your body. Tell me one of them. Ingestion. So kids under 2, highly susceptible to ingestion. So you got to watch what's around. All right, what's another one? Inhalation, good. And when you think of WMD disasters, weapons of mass destruction, you think of certain gases. What is a broad criteria for a weapons of mass destruction gas? Should it be lighter than air or heavier than air? Heavier. Why should it be heavier rather than lighter? Why do we not care about lighter than air bad things? It all goes away. We don't care about it. It just, unless there's a roof on your head, who cares? It's gone. So we worry about things heavier than air. Things heavier than air, this sounds really basic, but it is, goes down to the lowest level, right? Closest to the floor. Who is closest to the floor? You can have infants that become affected by gases that no adult gets impacted by because we don't breathe from our knees. We're just separated. So that's another way. So we said, what was it? Inhalation, ingestion. Tell me another one. Absorption. Absorption. What's it mean to have absorption? What is absorption?
Like topical?
Yeah, it comes over your skin, right? And so, remember we said kids under 2 have a tremendously varied surface to body mass ratio. How's that relate to absorption? Does that mean you're going to have more absorption or less? It means you're going to have more because I've got more surface area in which to get stuff. Okay, now that was only 3 of 4, and I'm okay with that. We'll stop with that for now. Smarty, don't go further. So 3 out of the 4, we can see why kids become more vulnerable, right? In a disaster. So that impacts some of triage. Now let's get back to triage. The topic of this specifically was triage. So let's spend some time talking about that. Tell me, just shout out, not too loud, everything you know about triage. What is triage?
You have to kind of sort through who's the most critical to the least critical.
All right. Criticality, I like that. So, somebody said sort, too. You said sort. Who else? Did you say sort? Okay, good. Anything else about triage? Whether it's peds or adult, the functions of triage are the same.
It's a quick look at what your injuries are.
Okay, so it's a quick assessment. I like that. Something else? This small group, y'all can, the AV people can jump in too. I know the answer to this. Tell me something else about triage. What else do you know about? Anything?
There's a lot of drama.
A lot of drama. Okay, I'm good with that. One of the rules of triage, interestingly enough, is if there is a lot of drama, you're probably really acute or not acute. Which one?
Not acute.
Not acute. As a general rule, the people who are sickest tend to be the ones most quiet. Why is that?
They're weak.
They're weak. They just physically can't do all the drama.
Too much pain to be moaning.
That's right. So when you do triage in any setting, and they do triage in gobs of settings, right? I mean, you do it in a disaster, you do it in a small car crash, you do it in the ER all the time. In fact, in the ER, you continually re-triage patients. But the tendency is to go to the person who is the most demanding, the person yelling, screaming, the person who smells bad, the person who looks bad. As a general rule, those are not the people that need your help most urgently. Okay, good. So I like this. There are 2 functions of triage. One is to sort, and the other is to prioritize. Somebody tell me the difference.
The sort is just to separate them out.
Okay.
To prioritize is to take the most critical first.
Yeah, okay, I'm good with that. Well, and it's not always even the most critical, it's to just somehow rank order them. So this is splitting them, right? And this is, it's ranking them, can we say? Okay. Now, there are schemas used in triage in a pre-hospital or an emergency environment, right? So there are a couple of things that we typically think of. START or ID Me or MASS or SALT. And there's one for kids that is typically Jumpstart. It's this quick little schema of I go down, I do this, I do this, I do this, and voila, I have my patient. And they're sorted into 4 or so categories. Anyone remember what they are? You can watch TV and know what they are. They're colors, right? Somebody tell me one of the colors. Red. Is red good or bad? Red is bad. Black is worse. All right? If red is bad, what would be good?
Green.
Green, yeah. All right, good. Green is good. And who said it? Yeah, yellow is the middle. Okay.
Looking at orange too.
Really?
Mm-hmm.
Wow, fascinating. Let's go with that for now. They also can throw in grays and all kinds of other colors, but let's go with that. Is that sorting or prioritizing?
Well, both. You're sorting
Tell me
them-
about it.
You're sorting them into a priority order.
Okay.
Okay, you're sorting bad, pretty good. You got your greens and you got your reds.
Okay.
You've sorted them, but you've sorted their priority at the same time because greens are those that are typically non-critical, non-priority.
Okay. I would argue, I'll take that. I would argue that this is sorting. It's grouping people by classification. These are bad, these are not bad. It's not necessarily prioritized. I can see your argument that it is. One of the problems with the schemas that are out there for triage is they tend not to prioritize. So in other words, if I use Jumpstart and my son Jonathan, who is 2 years old, a toddler, so 3 years old, thank you, then he hits red, yellow, green, regardless of whether he's the only patient or there's 100 of them. The sorting is the same. So he's not prioritized, he is sorted, right? Does that make sense? That's a problem because we rely on this, providers rely on that to prioritize. They're relying on that function to help them know what to do first. And the schema is never designed for that. We have a problem, right? Okay. Do we know anything else about triage?
And mass disasters, then the prioritization doesn't always work the same as day to day.
Okay, I'm good with that.
That's what I was going to say, day to day, ENT might, black gets the biggest priority, or red gets the biggest priority, but, for example, in Katrina, when Memorial was evacuating, they did what's pretty standard triage for an event like that, a mass casualty. The DNR patients and the sickest went last.
Uh-huh. Okay, I'm good. All right, so that takes me to another topic. Somebody tell me what a disaster is. So if we're talking about triaging in a disaster, let's talk about, you see how advanced this is. You see why you should have waited on the gift. I mean, doing triage in a disaster. What is triage? What is a disaster? We're heavy hitters here. Tell me what a disaster is. And it's not when I try to balance my checkbook. Go ahead.
A disaster is typically, from my understanding, is outside of one community's control. It spans over multiple communities or a broad area.
All right.
Something that overwhelms your daily standard. Something you as a community cannot handle on your own.
Overwhelms daily standard. Like that. Anything else?
What I always tell people when we say an emergency or disaster, it confuses a lot of people, but an emergency is an event that can be handled within the daily operations of the fire department or the police department. And then a disaster is something that exceeds their daily capacity. So, for example, the fire department could easily handle, let's say, a 2-apartment fire, but if they have 150 apartments on fire, then it becomes a community level disaster.
Okay.
Because you have to do the evacuations, you have to do the sheltering, the feeding, and all.
Okay. Anything else? This room's been noticeably silent. Anything else on a disaster? You get a bye. You talked the last time really well. Very eloquent. I learned a lot. It was neat. Okay. Anything else on a disaster?
Does it invite a community response? It's like a multiple.
Okay. Could be multiple agencies.
Resources.
Now, we're not going to do it now, but if you're thinking about it sometime, I challenge you to list out everything that you think of as a disaster and look for the common thread. And that's your definition of a disaster. So you have to start teasing apart, because a lot of people come to it and say a disaster is a mass casualty, or a mass casualty secondary to some kind of traumatic event. Well, no, not necessarily. Sometimes people say a disaster overwhelms the community. Maybe. Sometimes they say, yeah, well, whatever. Try to figure out what you consider is a disaster and then the common thread. Now, let me suggest for the moment that a disaster overwhelms resources. I'll take that as a working definition. Since I'm standing, I get to take that for now. So a good working definition of a disaster is when your resources are or are likely to be overwhelmed. Can we take that one for now? Okay. If that's the premise, then what are the resources that are overwhelmed? According to Rogers' rules, there are 4 types of resources. I told Dawn we would hit Rogers' rules, and that's the real reason she's here. She was like, man, Rogers' rules, how could I miss that? Rogers' rule. 4 types of resources. Anyone want to guess? We've heard them today.
Human resources.
Okay. Let's say people. Something else?
Facilities.
Equipment.
Okay. Let's clump all of that stuff in a highly technical term of stuff. So stuff can be supplies, which tend to be thought of as disposable, you can get rid of, or equipment, non-disposable, or facilities. So it's all stuff. All right, those are the simple ones. There's one other sort of simple one.
Money.
Money. Here's the tough one, but the really important one. What is it?
Time.
Not time. That's a good guess. Rogers' rule, I will suggest the 4th resource is information. Okay? And I will go on to suggest, again, push back on this if you don't like it, that in most disasters, the resource that is initially in shortest supply, that. Right? Okay. So, we said disaster equals resources, and we listed resources, and we said that information is initially, because what we're really talking about is gap, trying to find the gap. A disaster is going, what do I need and don't have enough of, and you've got to have enough information to figure out the right people's stuff or money to get, right? Otherwise, you got the wrong people's stuff. There is no such thing as wrong money, but you got the wrong people or stuff, right? So information becomes initially the most scarce of the resources. This is interesting. So if disasters equal resources, then let me suggest disaster management is what? You whispered it. What is it?
Information management.
Yeah. Resource and information management. And the angel sang. Right? Because you go and approach a disaster and you're like, this is so overwhelming, where do I even begin? And it starts with, what is the information? What's the gap? Then from there, I can figure it out and start building a response. True? Okay. Now, Rogers' rule number 1, Rogers' rule number 2. There are 3 types of information as it relates to a disaster. Now I'm writing sideways because I can't, so just kind of work with me. On the camera, kind of adjust it and make it look good. Kind of protect me, okay? All right. One is you have it and need it. So if you have the information and you need it, let's do that differently. What do you do with it? If you have information and need it, what do you do with it?
Share.
Use it. Have it and need it. You use it. And somebody said sharing it, and that's another way to use it. All right? Or you can have it and not need it. What do you do with that?
Share it again.
Uh-uh.
Somebody else may need it.
If you have it and you don't need it, what do you do with it?
File it because you don't know if you may need it.
Okay. I'll take that, but I'm going to say generally discard it. And I'll get to that in a second. Then the 3rd type is what? You should see a pattern here.
Don't have it. Need it.
That's right. I don't have it and do need it. Now what do I need to do? Get it. Forms the basis of your disaster response, right? It's about information management and where. Dawn's sitting back there going, this is fascinating, not really, but you're not talking about PEDS triage. What are you doing? I'm going to get there. All right, let me tell you a story about this. In the first Virginia Tech shooting, and that's kind of a hideous kind of claim to fame anyway. I mean, first implies there are more, and there are. How crazy is that? But in the first Virginia Tech shooting, we at Carillion were the first due trauma center, and we were all stood up, and we were loaded for bear. And as an example of that resource management, you could literally walk from one side of our ER to the other on surgeons' backs. I mean, there were too many. We had to get rid of them. It was crazy. Had no patients, had a lot of docs. We couldn't find good, accurate information. We were trying to figure out what was going on. And nobody even knew what was the right question to ask. I sure didn't. I was relatively new to the position at that time. We had different people trying to figure stuff out. In the absence of accurate, good, meaningful information, people will always what?
Fill in the blanks.
Fill in the blanks, and they will do it with good information or bad information.
Any they can find or make up.
Yeah, and they tend to, if they're making it up, go to a worst case scenario, has been my finding. So
post it on Facebook.
That's right, yes, and then they share that, okay? That's a key to emergency management too, disaster management. So it says, if I don't have good information and remain silent, what's everyone else going to do? Oh my gosh, it must be really, really, really bad. I should tell everyone and help them out. Okay, so you got to get information out. Even if it's nothing more than, I don't know a lot yet, just hang tight, but I'll tell you more as soon as I know it. In that first Virginia Tech shooting, though, we were trying to figure out what was going on. And the thing that started coming out was the number of fatalities at the scene. So we heard stuff like there were 5 fatalities, we heard there were 50, we heard there were 500, then we heard there were 35. It's just all over the board. And I, being a relatively new emergency manager at that point, said, I got it. I was my dog with a bone. I can go find out. I can work the phones and find out the number of fatalities. So I was hard at work on that. And there was a good friend whose name is Rick McGraw. He's no longer at Carillion, but he was the director of the emergency department then, and he pulled me aside ever so kindly and said, what difference does it make? Why would I care how many fatalities were at the scene? In healthcare, why do we care about fatalities? Do it? If you're part of DMORT, you do. But as a hospital, I didn't need to care about that at all. I had information. I was chasing information that had no relevance to me at all, which was consuming all of my time rather than focusing on what I really needed to do. See that? Concept. If you don't have that, when you this whole thing kind of falls apart fast. You got to make sure you're focusing on the right information. Now, let's go back to our pediatric triage. Remember us saying red, yellow, green, and black? And we said that's sorted, but we said that what we actually try to do is what? Prioritize. Did it actually prioritize? Maybe not. So maybe we were using a scheme to get us to a point that really didn't get us there. I will argue that we have, in an effort to make things easy, dummied down healthcare response to a disaster. Certainly triage. So we have tried to create these quick little flow charts of I can walk up to any person, spend 30 seconds, triage them, and move on. And in reality, it may not get me the meaningful information that I really need. Does that make sense? Hopefully, I have connected this with you of why is it important to get the right information. So if I don't have the right information, can't do any of my other response. I can't get the right people. I can't get the right resources. I'm all lost. Having the right information is key. Following me on all that? Okay. Let me tell you. So the question, so what, Roger? I had a mentor that every time I would tell him something would answer with so what. It's highly offensive but effective. Any of y'all have mentors like that? Tell you what, you have to be thick-skinned to have those guys. So what would be the question? Well, let's look through and see what would be useful pieces of information in pediatric triage. We good with that? Let me draw a highly technical map and you will immediately see my artistic ability, okay? Like it? This is the interstate system in Southwest Virginia. This is Interstate 81. This is 581. Roanoke is over here. And there is our Carilion Clinic Children's Hospital, which is a trauma center and a tertiary care thing. Then there is this other hospital, which is a large medical center. It's what's the opposite of a tertiary? It's a middle or more advanced. You know, they do a lot of stuff, but it's not a trauma center, not children. And way up here, there is another hospital that's a critical access hospital. What's it mean to be a critical access? You'll know this. 25 beds or less, small community hospital, essential to public care, but kind of not an acute size hospital. The resources are scarce. This distance is about 50 miles. This distance is about 5 miles. Okay, so we're not to scale, right? See all that? Okay, I love this. Are we having fun yet? Did somebody say That would have scared me more. Yikes! All right, if I have one kid hurt right there, which hospital should I take them to? Take them to the children's hospital? Do we all agree with that? Okay. All right. If I have one kid hurt over here, where should I take them to? Okay. So even if they're a little closer to this one, they're still close enough to this one where I would go here? Is that the reasoning? Or not? Tell me, how did you decide to take them to the children's hospital?
I would assume that there would be professionals who are specifically trained for peds.
Okay, I'm good with that. I like that. So if they're here, they're gone. If they're here, they're gone. Good. Now, what happens if that same kid is there? Let me give you more information. Let's say this is a 13-year-old with lacerations, nothing else. Where are they going? Okay, right here, closest hospital, right? Good.
Is it laceration of their femoral artery?
No. Good question. No, basic lacerations, cuts, bruises, that's it. Okay, good. What?
If it was more severe, it would be the closest one to stabilize, then transfer them.
Okay, I'm good with that. All right, so, well, let's do something like that. Now let's say an 18-month-old with those same lacerations. Where's it go? This one or this one?
That one.
This one?
Oh,
This
no.
one.
That one, the special. For
The
children.
special. Would you agree with that?
Yes.
Why?
About-
Why? Same location, just a slightly different kid. The only thing that was different in this kid is what? Age.
Where are the lacerations? You're talking to pediatric patients.
Just lacerations on the, there's not a trick question on this.
But no major significant bleed. Closest hospital.
It's an emergency.
Okay.
Lacerations. Because there is a bleeding there. So you're gonna go to the nearest hospital.
Okay. Go ahead.
I would say what stands out to me, again, apologize, I'm not medical, but from 13 years down to 18 months, it seems to me that there's a different equipment that needs to be used as far as beds and all that kind of stuff. So
That's
my
very
question
true.
would be, does that small community facility even have the equipment to deal with an 18-month-old?
Like that. Roger, like that. Okay, so if they get here, the EMS units, the ambulances, the woo-woo, they come. Do they need different equipment? Yes. Does the ambulance come with stuff to take care of an 18-month-old and a 13-year-old? Yes. In Virginia, that's not a problem. Done. Voila. They get to the hospital. They need resuscitation kind of stuff. Now, I said that this was simple laceration, so they wouldn't need a resuscitation. But if they needed airways, advanced infusion, so IV catheters, all that kind of stuff, will the hospital have all that? In Virginia, they will. Should have that. Now, tell me, all y'all moms, one thing an 18-month-old will really need. Mom, tell me something else they'll need. Diapers. Will this hospital have diapers?
Yes, of course.
Maybe not. Tell me something else an 18-month-old will need. What kind of a bed do you put them in? Okay. Will this hospital have a crib? Maybe not. What else will that 18-month-old need? Formula. Will this hospital have formula? Maybe not. So, part of our age difference is not, relates to the supplies we need, right? So, we need to make another list. Age, and part of age is supplies. And our supplies could be either EMS or hospital. And at the hospital, they can be the first aid, the little cross, or other. Right? Who would have thought that whether the hospital has diapers could influence where the kid goes? But should it? Maybe it should. Is that in my schema of Jumpstart? Is there any place in Jumpstart that asks the questions, does the receiving hospital have a diaper?
What is Jumpstart?
It's the triage scheme that is typically used to assign red, yellow, green, black in Virginia. All right, let's go with another one. What happens if the kid here is, let's go back to the 13-year-old, with a fractured femur? Fracture means break. Femur is the big bone. You can lose a little blood or a lot of blood in that. A lot of blood. You can bleed to death with a femur. So, which hospital do they go to here? They go here or here?
If he's stable, he's going to children's. If he's unstable, he's going to community. If he's stabilized, he's going to
Okay, you said by how? You said the word flown. I like that. Let's talk about flown. So, if I can get a helicopter here, now where's the patient going? Yeah, they're heading out. Okay. What happens if I don't get a helicopter? If it's just a ground ambulance? Then where are they going?
The closest place.
Then they're going here. Okay, so now we have another thing that's impacting our patient. We said age, supplies, method of transport. Right? Do we agree with that? Okay. Now, let's say that, well, let's stay in this one. Let's say that my crash is there, and let's go back and say that it's a car with two people, my 13-year-old with lacerations, but dad, critical trauma. And they're going to fly in. Now where's the kid go? In an ideal world, where would the kid go?
Should go with dad.
Kid should go with dad, right? We want to keep families together. Anyone who's read PED problems in a disaster, one of the things is family separation. takes forever to get them back together. Why is that?
Transportation.
Yeah, well, some of it's paperwork. Some of it is even simple identification. If you got a little, they can't tell you, hey, my last name is Smith, right? Okay. So let's try to keep them together. So we said age, supplies, method of transport. Now what are we adding? Family.
Family.
All right. Now, let's say, aren't we having fun? Don't you love scenarios? All right. Let's say that you have 6 13-year-olds, all with significant shortness of breath. That's not, it's a bad person. It's SOB stands for shortness of breath. Secondary to paint in a school. So that's what kind of effect? It's respiratory effect. We said it's not ingestion, it's what? It's inhalation. Okay, good. Where did those go? How am I going to treat kids, multiple kids who were around a room that was painted and were overcome with the fumes?
Get them outside.
Yeah, what do they need? Fresh air. So which hospital do they go to?
None.
Or this one?
Yeah.
Right? Okay. So I don't need to send them away. Even if they seem pretty critical initially, the treatment on that's pretty simple. Give them fresh air and voila, it's miraculous, right? Good? Okay. Now, what happens if you have those same 6 13-year-olds, still shortness of breath, but it's a secondary to a gunshot wound in the chest. Active shooter punches them in the shoulder or something. So now they can't breathe because they've got other stuff going on. Now where do they go? Specialty hospital?
Yeah.
Okay, all things being equal. Okay, so what was the difference?
These are injuries.
The lungs.
It was more than severity because we classified them both as critical. It was what? Type of injury. Okay, right? Because remember us talking about disasters at the beginning? We talked about, we tend to think of it as mass casualty secondary to trauma, and then we were talking about, well, it could be some other things. So it could be like a WMD or we talked about pain exposure. So 5, type of illness or injury.
Now, does Caribbean have what we have over here in our region in regards to?
Absolutely.
Because
Yes. Yes.
If you take 6 gunshot wound victims that are pediatrics to one facility, is that going to overwhelm that one facility where another one can actually take care of it?
Oh, that's really good. Did you steal my notes? So,
So you can't take it anywhere.
let's say there's something down here that is also sending patients to this hospital. Now, one of the premises that we in hospitals don't like, we like solving disasters. We don't like relocating disasters. It is a bad, bad, bad premise to take the disaster from wherever you have it and move it to wherever I am. Let's work together to fix it, but don't just move it, okay? Right? So, yeah, one of the questions is how much capacity do you have anyway? If we're talking about resource management is not only at the scene, it's also at what's being offered. It's supply and demand. And this is demand. This is supply. And all of this, we're talking about the equation between supply and demand. What's needed and where can I find it easiest, right? So you have to think about what's the supply in a children's hospital. You brought up a really good question. In our hospital, again, we're a big hospital. We're licensed for over 800 beds. We're a level 1 trauma center, a children's hospital. We've got a 60-bed NICU. We can go on to yada, yada, yada. When I ask our docs, how many kids can you take care of at once from the scene of an incident, they said, wow, 6 would really overwhelm us. Now, I've never done it, but I'm willing to bet if we go to her colleagues in Roanoke City or county and say, how many kids do you think you could send us before overwhelming us? How many do you think they would say?
All your beds.
I was going to say, I suspect they would go, doesn't matter, we're going to ship them all to you anyway. They sure aren't going to come up with a number of 6. They're going to go with a higher number, I suspect. You're disagreeing. And I'll take that, but I think a lot of people would
like to divert pediatrics, specifically pediatric trauma. They don't want that.
Well, right, but for a children's hospital, they're going to go, oh, well, you just get them all, right?
Yeah, so from like
For children's hospital,
CHKD
yeah.
here, around here, people
Right.
probably have the assumption that they can handle whatever they send to CHKD.
Okay, so we can keep playing scenarios out, but we've done some fun scenarios, and we've come up with some other things that impact our decisions. Our resource allocation, right? Talked about age, we talked about supplies, and that was kind of interesting because we talked about not just first aid supplies, but all those other mama supplies, diapers, formula, a bed, that kind of a thing. If you want a fabulous hospital bed for kids, for little kids, go to Kohl's. Get a pack and play. That is, in fact, Kohl's has in their national program, they work with children's hospitals to help parents who don't have money for big cribs to get a pack and play, because a pack and play is a safe place for kids to sleep. So that works in the hospital too. So we talked about age, we talked about supplies, we talked about method of transportation. Remember, we talked about whether it's a helicopter or ground and some of that. We talked about geography, distance. We talked about where the family is. We talked about the type of illness or injury. All of those things come into play when we make the sorting and the prioritizing decisions, right? Because it impacts the resources we need. Does that make sense? Mm-hmm. Okay. What's that teach us then? What's our so what? What's our take-home point? It is. That's exactly right. Triage is not as simple as triage.
It makes me very grateful for the Regional Hospital Coordination Center.
Mm-hmm.
That's what I get.
Yeah. All right. Triage. This is kind of, there have been some, I think, I'm biased, but I think some key concepts in this. We had Rogers rules, disaster equals resources being overwhelmed, and we talked about the 4 rules or 4 resources. Talked about information management. We talked about this supply and demand thing, and we recognized that all of those, none of those, are actually just quick 30-second decisions. And yet much of what we do in disaster planning is based around quick checklist 30-second. My plan is based on, if you hit this, you go, I'm not thinking about anything else. Is that a good plan? It's a bad, fraught with peril. We can feel like it's a really good plan, but if we stop and think, it's not a good plan. At the scene of an emergency dealing with special needs populations, what do we need? Not only rules, but we need to do something else. We need rules and we need gray matter. You gotta think. It's kind of an important thing, but in a lot of disaster courses, you'll hear, follow this plan and you'll always be safe. Follow this scheme and you'll always be safe. And what I'm trying to do is debunk some of that. Does that mean the plans and the schemes are bad? No. It means they're guidelines, they're framework, right? But at the end of the day, you've got to have critical thinking ability. So, how's that impact your plan? So if we walk out of here going, okay, so what, Roger? What do I do? What's that mean? It means you need to figure out, ask some of these questions, whether it's on pediatric triage or adult triage, some of these kinds of questions in advance so that you're building them taking them into account in your plans. Does that make sense? Go ahead.
Something as simple as knowing what is have which services. Like you're saying, do they have doctor's formula? Do they even have a pediatric in that facility? Is there an OB area? We used to have in Virginia Beach, Bayside, used to not have any obstetrical care at all. So
Right.
if you had an OB patient 2 doors down, you still transferred to a different hospital.
Yeah, you know, in much of at least rural Virginia, and I can't even imagine in Alaska, but in much of rural Virginia, it's like you say, the natural default is I send the kid somewhere else. And even if the hospital can handle the resuscitation, the medical part, they tend not to think of what are you going to do when they poop. A kid, no matter how stable or unstable, isn't going to stay in a poopy diaper long. It just doesn't work, right? But most of us are thinking about, do I have the right dose of atropine, which is an important question, rather than do I have formula in a diaper? Okay, so that's my take-home point out of this. What?
One of the other things you gotta have to, when you were talking about the shortness of breath, you've gotta have something too that lets you move beyond symptoms into underlying causes, like distinguish between, because if you have this pediatric patients and and you're not sure what the response is, that also determines, so you've got to be able to go beyond just recognition of symptoms.
Oh, that's really
into
good.
some type of diagnostic.
That's really good. We need to wrap up, and I don't want to cut you short. That's really good. Let me say one other thing on peds, and this is really important. Even the most advanced clinician, at the end of the day with peds, will go, I just have a feeling. I mean, you can see pediatricians from forever, pediatric intensivists, they'll go, just have a feeling. Follow your feelings with kids. That's different with adults. Adults, you can really sort and prioritize based on vital signs. Kids, you can't. So at the end of the day, if mama says, I can't put my finger on it, but something's just not right, you got a problem. If the ambulance crew goes, I can't put my finger on it, but something's not right, you got a problem. If you get to the ER and the nurse and doctor are like, I just can't put my finger on it, but something doesn't feel right, you got a problem. So you have to think a lot, but you also have to follow the feeling. Okay, quick wrap around the room. Tell me one thing you learned today.
The whole process of the triage.
Okay.
Was all new information for me.
All right, good. Tell me one thing you learned today.
Yeah, basically the same thing.
All right. Tell me one thing you learned, because you were answering good questions.
That kids and adults are 2 totally different aspects.
Yeah, they're not many adults. Good. Tell me one thing you learned. Yeah, go ahead.
My difference between the shorting and the prioritizing, not really thinking of the prioritization aspect of it.
All right, good.
And I think you really have to think outside the box.
Yeah.
And really look at your situation.
Yeah, that's really an important concept, isn't it? I have to think. I have to think. Okay, good. Dawn?
I just really learned how much goes into, because we've had these conversations as a working group, that there's more than just the red, yellow, and green that has to be considered. Again, I wouldn't have thought of, if you said, hey, here's a patient, triage it, well, do they have diapers? When I think of equipment, I think of a bed that fits.
And most plans are written like that. And most people who write plans are thinking like that. You're exactly right.
And it makes me wonder about our shelters.
I was just thinking, something as simple as a shelter. We have trailers that have cots in them. We have medical trailers with medical surge beds. We don't have one trailer.
Yep.
Well, there's no pediatric medical equipment in SSUs. Is there?
Interesting. Yes,
Is there? Yeah.
being able to get a handful of those and having them else.
And they stack nice, too.
Yeah.
Pack and plays are fabulous. Okay, Sarah, did you learn anything?
Yes. Again, the whole thing of going, you can't just use the checklist, and there's too many you're thinking clinically, but there's too many just basic, almost day-to-day logistical things.
Oh yeah,
that
that's a
go
really interesting
far
point.
Triage is far more than clinical
Mhm.
assessment.
Good. All right, other people are coming in, and I'm pretty certain it's not just because they've heard I'm a great speaker. So let's see. Dawn, can you pull out a ticket, and then we're done.
All right. So we're going to do a door prize and then give Roger a big thank you. Does everybody have a ticket? You got a ticket earlier. Should work.
Yeah, I got a ticket and,
We're going to do an emergency essentials thing.